Well, I want to thank the members of the Education Committee as well as Debbie Kovacs for putting together this meeting, which is really the meeting highlight of the year for those of us who love medical dermatology. So thanks very much. I was asked to talk briefly about new data and emerging trends in vasculitis, and I have no relevant disclosures for this talk. So our objective today is to review the latest developments in the world of vasculitis in the skin. We're certainly going to talk about clinically relevant developments in skin vasculitis, but I also want to give you a glimpse into what's happening in the broader world of vasculitis because I think it'll be informative. We'll speak about current and evolving nomenclature and classification schemes, new data guiding evidence-based evaluation of vasculitis presenting in the skin, in other words, how we work these patients up, emerging trends and targeted therapies in the management of systemic vasculitis, and finally, what's next in skin vasculitis and our engagement with the Vasculitis Clinical Research Consortium. So let's first talk about nomenclature and classification. Now, you'll all have seen a schematic like this, breaking down types of vasculitis by vessel size. And what the 2012 Chapel Hill Consensus Conference nomenclature did was provide an expert-driven definition based on clinical features to subcategorize these different diseases. That nomenclature includes cutaneous vasculitis, but the full scope of cutaneous vasculitis not fully addressed. So for example, skin-limited IgA vasculitis or Hennig-Scheinlein purpura, something we recognize exists, not included in Chapel Hill, or erythema induratum, not included in Chapel Hill. And so for that reason, a dermatologic addendum to the Chapel Hill nomenclature was created to standardize the names and definitions of these various types of cutaneous vasculitis. And this manuscript importantly recognizes that cutaneous vasculitis can represent a cutaneous component of systemic vasculitis, that is, a skin finding in systemic vasculitis, or a skin-limited or skin-predominant variant of systemic vasculitis, or finally, a single organ cutaneous vasculitis that does not have a systemic counterpart. So for example, it acknowledges the existence of skin-limited IgA vasculitis or skin-limited cryovasculitis, for example. It includes types of single organ vasculitis like nodular vasculitis or erythema induratum or EED. And it provides a dermatologic perspective as well as an enhanced understanding of cutaneous vasculitis. But what neither Chapel Hill nor the dermatologic addendum do is provide evidence-based diagnostic criteria. These, remember, are just expert-based definitions. And so that brings me to talk about this study, DC-VAS. It's a diagnostic and classification criteria and vasculitis study. It's the world's largest vasculitis study, including 6,800 patients from 135 sites worldwide. And the objective of this study simply is to develop and validate diagnostic and classification criteria for systemic vasculitis for use in practice and clinical trials. This group has formulated already a new diagnostic criteria with point systems based on various clinical and laboratory and histologic findings to arrive at a diagnosis, evidence-based diagnosis for large vessel vasculitis and also for ANCA-associated vasculitis. And so these things are slowly winding their way toward publication. And they really are the future of evidence-based diagnostic criteria for vasculitis. Well, we were able to acquire the dermatology data from this study. And we asked the question, how does systemic vasculitis present in the skin? And when we see it in the skin, what is its significance? So for example, in ANCA-associated vasculitis, we found that skin lesions are a common presenting finding in 30 to 50% of cases. The most common of those findings is petechia and purpura, whereas allergic, nonspecific findings like urticaria, itching, eczematous dermatitis, those things are most common in Church-Strauss or eosinophilic granulomatosis with polyangiitis, as you might imagine. And finally, we found that skin biopsy is underutilized, performed in a minority of cases, despite fairly high rates of diagnostic confirmation. And so what these merely descriptive data show us is that the skin is important. A good skin exam is important, and working together with dermatology colleagues is important for diagnosis of these patients. But it turns out the skin is important not just for diagnosis, but also for prognosis as well. Among about 1,200 patients with ANCA-associated vasculitis that we looked at, those with cutaneous lesions were more likely to have systemic manifestations of disease, and in fact, more likely to have severe manifestations like glomerulonephritis or alveolar hemorrhage with a hazard ratio of 2 for granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis. And so the skin may have prognostic as well as diagnostic importance. And it speaks further to the importance of dermatology and the skin and how we fit into the puzzle of diagnosing and managing these patients. So the work with the DC VAS dataset is ongoing for evidence-based classification of other types of systemic vasculitis. And so is our work and our analysis of the dermatologic data regarding how vasculitis presents in the skin in various subtypes. So next, let's talk about cutaneous vasculitis and evidence-based evaluation. So this is a fairly common scenario that you might encounter. 61-year-old man with recent MRSA infection treated with vancomycin, who is now presenting with palpable purpura on the extremity 7 days later. Skin biopsy demonstrates small vessel vasculitis. No IgA is present on direct immunofluorescence, and his exam and review systems are otherwise not concerning. So what do you make of this patient? How should you evaluate him? What labs do you want to order? Well, when a patient presents with lesions suspicious for vasculitis, our initial workup should try to answer 3 basic questions. The first is, are these lesions in fact vasculitis or perhaps some mimicker? This is where a biopsy and good ClinPath correlation comes into play. The second, are other organ systems involved? And the third, are there findings which help establish a particular diagnosis? Well, we know that vasculitis may be and often is confined to the skin, but systemic vasculitis and underlying disease states or triggers must be excluded. But how common are those important underlying disease states really? Do we have data to answer that question? Well, here I want to acknowledge my collaborators, Andrew Walls and Arash Mustaqimi up at Harvard. We've worked together to compile a cohort of patients from Penn and Harvard with biopsy-proven small vessel vasculitis of the skin. And among 440 patients with small vessel vasculitis, the ultimate diagnosis in 80% ended up being a skin-limited leukocytoclastic vasculitis, 12% IgA vasculitis, 3% connective tissue disease, and a small minority of patients ended up with a diagnosis of other types of systemic vasculitis. Of those patients with skin-limited LCV, 60% were idiopathic, and the remainder were secondary to drug or infection, and a small minority underlying malignancy. And so what these data show us is that cases of systemic vasculitis or connective tissue disease presenting as small vessel vasculitis of the skin are uncommon. But of course, they're important not to miss. So how should we identify and distinguish those patients? Well, at the end of the day, there's no substitute for a thorough review of systems and exam to separate patients with skin-limited vasculitis from those with more significant systemic involvement or underlying disease. And so we'll certainly be interested in symptoms like joint pains or abdominal pain, sinusitis, paresthesias, numbness. Those things might all be red flags for various types of systemic vasculitis. Fortunately, in most cases of small vessel vasculitis of the skin, sort of the typical palpable purpura presentation that we might encounter, significant systemic manifestations are unlikely. Arthralgias are fairly common. Having puffy, uncomfortable ankles when there's lots of palpable purpura in the vicinity, that certainly is quite common. But frank synovitis or arthritis in areas remote to where there's skin vasculitis is rare and suggests the presence of systemic disease. Other symptoms, constitutional symptoms, neurological, pulmonary, these are all red flags for other types of systemic vasculitis. And if one or more of those symptoms is present, a targeted workup really should proceed to identify potential extracutaneous manifestations. Unfortunately, and you may sense a trend here, there's no standard protocol for this workup. It really has to be guided by the clinical signs and symptoms. Most episodes of small vessel vasculitis of the skin are skin-limited and self-limited, resolving within about 3 to 4 weeks. And so this tells us that perhaps not every test needs to be ordered in every patient, because most of them are skin-limited and they're going to go away on their own. And in fact, maybe we don't want to order those tests because false positives or irrelevant results can be confusing and can cause consternation. But at the same time, serious internal organ dysfunction does rarely occur. And so this is the most common trap that we as clinicians can fall into. We can either order too little, that is not get a urinalysis to evaluate for renal involvement or ignore some systemic symptom that the patient has, or we can order too much and we'll be forced to grapple with that low positive ANA or random anticardiolipin positivity and questioning ourselves, what do we do with these results? And sort of wishing we didn't order them in the first place. And so this is the balance that we need to strike in evaluating these patients. So what do I do? Well, for an initial episode of small vessel vasculitis presenting in the skin, when that presentation is straightforward and there's a negative review of systems, I'm only getting a CBC, a BMP, and a UA with micro. Of those tests, the urinalysis is most important because the patient may not have symptoms of glomerulonephritis, but if there's evidence of renal involvement, that certainly will change management. So if there's blood in the urine or protein in the urine, it may be appropriate to get the help of nephrology to spin the urine and look for red blood cell casts there on the left, or dysmorphic red blood cells, those little Mickey Mouse-like structures there on the right. At the same time, additional indiscriminate workup is unlikely to be helpful. And here again, I'll look to data from our combined cohort of Harvard and Penn patients presenting with biopsy-proven small vessel vasculitis. Well, in that cohort, acute phase reactants, ESR, CRP, they're rarely normal and therefore rarely helpful. That is, they're almost always elevated in patients with skin-limited disease and therefore are not a useful indicator of systemic involvement. Whereas things like ANCA and SPEP, these tests are rarely abnormal and therefore really should only be ordered when they're indicated. If you're thinking specifically about ANCA-associated vasculitis, for example. Screening radiographs, that is, radiographs that are ordered because the patient had a biopsy that showed vasculitis, these kinds of imaging studies are rarely positive, only about 5%, and are extremely insensitive as a screening tool. And so these data suggest that testing should be reserved for patients who have evidence of systemic involvement based on their clinical presentation and other findings. Additional workup is, however, indicated when there's concern for systemic involvement. Any organ-specific targeted workup should proceed based on the findings on the review of systems and exam. So how about patients who have concerning symptoms, or maybe now it's their second or third episode of skin-limited vasculitis or cutaneous vasculitis of the skin? What do we do with those patients? Well, certainly we'll get those basic labs, but now we may be interested in infectious serologies like hepatitis, HIV, and antistreptolysin O, a rheumatologic workup, including ANA and rheumatoid factor, which can be a surrogate for mixed cryoglobulins, as well as some second-level tests like SPEP or immunofixation, C3 and C4, ANCAs, cryos. These tests can help give us, in the appropriate clinical context, a better understanding of potential underlying disease states. By definition, if skin lesions suggestive of medium or small to medium vessel vasculitis are present, that is retiform purpura, nodules, larger ulceration, you should absolutely make sure that you're undertaking appropriate workup for those conditions: cryovasculitis, ANCA-associated vasculitis, polyarteritis nodosa. So in summary, for a straightforward case, initial presentation of small vessel vasculitis in the skin with a negative review of systems, I'm only getting a CBC, a BMP, and a UA with micro. But if there are unclear triggers or other symptoms, certainly it's worthwhile to get infectious serologies, autoimmune serologies, as well as some of those second-level tests, and really any other workup that's warranted by the presenting signs and symptoms. So what I've just walked through is an expert-driven approach to evaluation. It's what you might see in a review article or an up-to-date chapter. What we're trying to head towards is an evidence-based, algorithmic approach to working up these patients. And that's our hope for what will ultimately come out of the cohort of patients that we've put together, that we'll be able to provide stepwise evidence-based instruction on how to evaluate patients presenting with small vessel vasculitis in the skin. So next, let's talk about the treatment of vasculitis, and in particular, targeted therapies. Well, this was a 20-year-old woman who presented to clinic with rhinitis, fatigue, fever, weight loss, and dyspnea. She presented to dermatology for these ulcerative skin lesions, but it was difficult to ignore the saddle nose deformity and the strawberry gingiva that she had as well. Her CT chest showed ground glass opacities. Her urinalysis had red blood cell casts and a creatinine of 2. And her skin biopsy showed small and medium vessel vasculitis with granulomas. And so this was a patient who had pretty florid granulomatosis with polyangiitis, GPA. So when we look at the ANCA-associated vasculitides, we really see a shifting paradigm. And specifically, a patient like the one I just described with severe GPA 10 years ago would have received pulse steroids, Cytoxan, plasma exchange, and a prolonged steroid taper. But due to a series of trials over the last decade, such a patient might now get rituximab, no plasma exchange, and lower doses of steroids, so much less toxicity. And there are recent and ongoing studies which are evaluating the use of rituximab for maintenance therapy, low or even no steroid regimens, as well as the role of complement inhibitors and other novel therapies for ANCA-associated vasculitis. So I'm showing here two articles published in the New England Journal, one a year ago, February, and one a week ago, February, that help illustrate this point. The first is the study PEXAVAS, which was a phase 3 trial looking at plasma exchange and glucocorticoid use for severe ANCA-associated vasculitis. And what this study found was that plasma exchange does not reduce the risk of end-stage renal disease or death, and that lower doses of steroids also do not increase the risk of end-stage renal disease or death. And in fact, the low steroid group was able to receive 40% less steroids than the standard dose group at the 6-month mark with fewer complications. Now, the second study, the one published last week, was called Advocate, and it was a phase 3 study looking at the use of avacopan, an oral C5a inhibitor for the treatment of ANCA-associated vasculitis. Now, this C5a receptor antagonist blocks the effects of C5a, which include neutrophil chemoattraction and activation, which are important for ANCA-associated vasculitis. Incidentally, this drug is also being studied for hidradenitis, and that is called the Aurora study. It recently read out its top-line results, which suggested efficacy in patients with early stage 3 severe HS. Well, in this study, patients after receiving induction therapy were randomized either to get avacopan or prednisone taper. And the findings were that avacopan was non-inferior to prednisone at week 26. It was superior to prednisone at week 52 and was associated with fewer adverse events. This was a quote from an accompanying editorial published in the New England Journal the same week, which said, quote, "The Advocate trial heralds a change in the treatment of ANCA-associated vasculitis that was previously unthinkable, the possibility of inducing disease remission without glucocorticoids. Its success will encourage evaluation of other targeted therapeutics and low or no steroid regimens." How about this patient? He's 46, he has asthma, allergic rhinitis, and peripheral eosinophilia, presents with severe urticaria, and then later develops mononeuritis multiplex or a wrist drop, and other cutaneous features of vasculitis like livedo reticularis and Church-Strauss nodules or palisated neutrophilic and granulomatous dermatitis there on the elbow. This is a patient who has eosinophilic granulomatosis with polyangiitis, formerly known as Church-Strauss. Well, here too, we see targeted therapies at work. A phase 3 study of mepolizumab, an anti-IL-5 drug, also published in the New England Journal, head-to-head against placebo for patients with refractory EGPA. And the results of that study showed that those who received mepolizumab had more weeks in remission, and there were more patients in remission on mepolizumab than on steroids. There was a lower relapse rate and a lower total dose of chronic prednisone. This is the first FDA-approved drug for eosinophilic granulomatosis with polyangiitis. And since then, there have been additional studies of other targeted anti-IL-5 drugs, namely benralizumab and reslizumab, showing efficacy for EGPA. So ANCA-associated vasculitis is and has been for a while the most active area of research in the vasculitis world right now. So if I had to show you a snapshot of what's happening in the broader world of vasculitis, this would be it. And I think what we can glean from this and take back to us in derm is that there's really this shift away from broader, more significant immunosuppression and towards more targeted agents. An improved understanding of disease pathophysiology has already and will continue to open up new pathways to target. So that brings me to talk about what's next for skin vasculitis, speaking specifically about dermatology and the VCRC. Well, what's the VCRC? Well, it's the Vasculitis Clinical Research Consortium. It's a member of the Rare Diseases Clinical Research Network. And it's a group that we've partnered with to help understand better the evidence-based management of skin-limited vasculitis. So for this patient, 48 years old, skin-limited cutaneous small vessel vasculitis, negative review system, unremarkable labs, including UA, otherwise well, but with chronic and recurring vasculitis of the skin. How would we treat her? Why? Based on what data? Well, unfortunately, there's a dearth of high-quality data to guide what we do here. There's only ever been one small randomized controlled trial for skin-limited vasculitis. That was with colchicine. It had 20 patients in each arm and lasted a month and unsurprisingly didn't show definitive results. Everything else we do, whether it be dapsone, azathioprine, other therapies, is based on case reports and expert opinion. The adequate dose and duration of therapy are probably important, but these are not defined either. And so that brings me to talk about Aramis, which is a study that we are doing partnering with the VCRC. It stands for a randomized multicenter study for isolated skin vasculitis. And our goal here is to determine via this comparative effectiveness research, what's the optimal treatment of patients with skin-limited vasculitis? Is it colchicine, dapsone, azathioprine? And we are randomizing patients to receive one of these three therapies, 1:1:1. And if they don't respond to the initial therapy, they can be re-randomized to receive a second. And so this is what's known as a sequential multiple assignment randomized trial. This is really a partnership between dermatology and rheumatology. We've expanded from the core VCRC sites to include additional sites in the US, Canada, and Japan, many of which are dermatology-led. And it utilizes the VCRC infrastructure without which we would be unable to do this kind of work. To date, we've enrolled 47 patients. It's been quite an effort to get that far, which makes me appreciate that colchicine study a little bit more. But we're well on our way, hopefully, to getting results from this study. These are some articles we published about the design, which just ups the ante that we have to come out with some actual results at some point. All right, well, as we're talking about comparative effectiveness research of existing drugs, what about targeted therapies? So, is there a pathway that we could perhaps address that's important for skin-limited vasculitis, or for that matter, IgA vasculitis, or polyarteritis nodosa, or hypocomplementemic urticarial vasculitis? Any of these? Is there a pathway, perhaps, that we could target? Well, we're doing this study with the VCRC as well. It's called CUTIS, Clinical Transcriptomics and Systemic Vasculitis. And this is another multicenter study where we're evaluating the transcriptome of cutaneous lesions in patients with systemic vasculitis. We're systematically characterizing histopathology, and we're performing gene expression analysis on lesional skin to define novel pathways to aid in classification and targeted therapies. Our clinical data and tissue are collected at our collaborating sites and transferred to colleagues at the NIH for the translational work. And so far, we've enrolled 63 patients with all different subtypes of vasculitis. And lastly, our final collaboration to date with the VCRC is called VASSkin, which is a skin vasculitis quality of life study, which is really an effort to understand the quality of life impact of cutaneous vasculitis, working together with what's called the Vasculitis Patient Powered Research Network, which is a partnership between the VCRC and the Vasculitis Foundation, which is a patient advocacy group. We've disseminated our survey through the VPPRN online patient network and have so far received 67 responses, still getting results back. And this is, fresh off the press, just initial analysis showing actually quite significant quality of life impact of skin vasculitis in all domains of the Skindex 29. So work in these multi-center collaborations continues as a way to leverage our combined experience for rare diseases research. Clearly, none of us on his or her own would be able to answer these questions by themselves. So in summary, we reviewed the latest developments in vasculitis and the skin. We talked about evolving disease classification schemes, data guiding evidence-based evaluation of skin vasculitis and how we work these patients up, trends in targeted therapies for management of systemic vasculitis, as well as our ongoing collaborative research in skin vasculitis. So with any remaining time, I'll take questions. Thanks very much for your attention.